Thank you, Dr. Abdullah, for the introduction. When you say senior electrophysiologist, you mean the oldest one, but I know it's
expertise.
Thanks for the invitation, and this is obviously a very important topic and complementary to all what have been said so far about the treatment of heart failure. So if we just start by going through the rationale for using devices in heart failure and how did the whole idea come for using a pacemaker for heart failure. This is also important to know that this is a new treatment. I mean, in about 20 odd years ago, we used to put dual chamber pacemaker for the treatment of heart failure. That's how we started, believe it or not. And we used to program the AV delay very short, hoping that this will improve heart failure. And we soon realized that we are not actually doing the patients any good. I mean, there has been some improvement, but that was because some patients were so bradycardic that it allowed the use of beta blockers. And I think that's how people came to understand that it's not the pacemaker itself, but the fact that the patients are no longer bradycardic and they're able to use beta blockers, and the benefit was because of the beta blockers. And all of us obviously deal with patients with heart failure day in and day out. And when you look at the ECG of patients with heart failure, you'll find that they have intraventricular conduction delay. The patient with heart failure almost always has a wide QRS complex. And the severity of the heart failure usually goes hand in hand with the intraventricular conduction delay. If the patient has moderate to severe heart failure, you can find more than 30% of these patients have a QRS complex that is wide. When we say QRS wide, we mean over 120 milliseconds by definition. Left bundle branch block obviously is also very common, and it's the one that we're always interested in because it actually impacts the prognosis of patients with heart failure, and left bundle branch block we know has a poor prognosis. If a patient has a preserved left ventricular function, you find left bundle branch block in 8% of patients. As the heart failure gets worse, the incidence of left bundle branch block gets more and more, up to maybe 38% in patients with moderate to severe heart failure. For those who are doing echo in the echo lab, if you look at the echo of a patient with significant left bundle branch block, I don't know if you can see the ECG at the bottom there, there's quite a wide QRS complex. And if you do tissue Doppler sampling from the septum and from the lateral wall, you can clearly see that there is a very marked delay in contraction between the septum and the lateral wall, and you can see the peak velocity there is very delayed in the lateral wall compared to the septum, and this is basically what we refer to as desynchrony. So you have a septum that is moved 1 second, and then more than 200 milliseconds later, you get contraction of the lateral wall. And what does that do to the physiology of the ventricle? First of all, it reduces the diastolic time, it weakens contractility, increases mitral regurgitation as well, and diminishes stroke volume, and hence no improvement or worsening of the heart failure. Now, what happens when you resynchronize the heart? Obviously, just you reverse all these bad sort of like effects of desynchrony on the ventricle. And in addition to that, obviously, it has been mentioned earlier on by one of the speakers, is that remodeling or reverse remodeling of the left ventricle is very important in improving left ventricular function in the long term. When you look at all the acute and the chronic effects of cardiac resynchronization, they're almost the same, and they continue throughout the therapy. You increase the systolic pressure, stroke volume, end systolic volume, and so on. Mitral regurgitation also, if you look on the left here, the patient before cardiac resynchronization therapy has severe mitral regurgitation. After implantation of the device, mitral regurgitation gets less, but if you optimize the device, and this is obviously very important, you don't implant the device and just leave it. You have to make sure that you optimize the device, and mitral regurgitation almost completely disappears. As I said, with ventricular desynchrony, I mean, if you have a QRS complex more than 120 milliseconds with 1 year survival, mortality is high. As the QRS complex gets higher, your long-term prognosis is also quite poor. And when cardiac resynchronization therapy started, initially, obviously, there was a lot of debate as to whether it's actually something that should be taken on at a wide scale or not, because most of the initial trials looked at things like 6-minute walk, NYHA classification, quality of life, hospitalization, and all these studies sort of like all of them showed that there is improvement in all these features. The big question is does actually cardiac resynchronization therapy improve mortality or not? And this is not actually become available until I think it's in 2004 or 2005, when the companion study, which is a very large randomized study, showed that the all-cause mortality and hospitalization is significantly reduced by cardiac resynchronization therapy, and since that time, it has become a feature in all the guidelines for heart failure treatment. Now, if we talk about the procedure, the difference between, you hear about CRT P and CRT D, and CRT P is just a pacemaker, and CRT D is a pacemaker plus a defibrillator. Obviously, the question that I've been asked to address today is, are we using appropriately? Now, the implantation technique is exactly the same, whether it's a pacemaker or it's a defibrillator. There's 3 leads. In the patient in sinus rhythm that we are talking about now, you have a lead that's implanted into the right atrium, another lead implanted into the right ventricle, and this is the difference between the P and the D. If it's a pacemaker, the lead in the right ventricle is an ordinary pacing lead, and if it's a defibrillator, then the lead will be a defibrillator lead, which has a coil or dual coil or single coil. The third lead is obviously the one that is destined for the left ventricle, and it's usually implanted extracardiac through the coronary sinus into one of the branches of the coronary sinus. This is unfortunately not always feasible, but nowadays we have different techniques of resynchronization using his bundle pacing and conducting system pacing on the left bundle branch. We won't go into details of that. But the procedure is basically the same, and this is important to know because sometimes a patient who is a candidate for CRT-D, they think, well, it's probably he's a little bit unwell or he's a bit frail, let us just give him a CRT-P, but that doesn't make a difference for me as an implanter. It's exactly the same thing. The only difference is the device and obviously the RV lead, as I mentioned. On the X-ray, this is what it looks like. You have the right atrial lead on top there, and then this is a left ventricular lead. As you can see it going across, it's actually going around the back of the left ventricle in the posterolateral branch of the left ventricle. On the lateral X-ray, you can see it going right at the back behind the heart, the left ventricular lead. It's important thing to notice the difference or the distance between the 2 leads, between the RV lead and the right atrial lead. You always aim for making really a very big sort of distance between the 2 so that you can resynchronize the heart better. The ECG after implantation changes from on the left side. You can see patient with wide QRS complex with left bundle branch block and a QRS duration of 140 milliseconds. After resynchronization, you see a very nice narrow QRS complex. And this is actually always a feature of a likely response in this patient. When the QRS complex narrows after the device implantation, you can predict that this patient is actually going to benefit from this procedure. Now, let us come to the indications for pacemaker or for CRT implantation. It's been alluded to earlier on, but we will go through that. Now, the class 1 indication for resynchronization therapy is really dependent on the ECG. The echo has no place to play. This is the first message that you have to understand. The echo has no place in choosing the patient for CRT. It's the ECG, and in the ECG, what you need or what you're looking for is the width of the QRS complex and whether the patient is in sinus rhythm or atrial fibrillation, because these are the things that will impact on the likelihood of success of the procedure in this patient. So the QRS ideally should be a true left bundle branch block. When I say a true left bundle branch block, that you have to have all the features on the ECG of left bundle branch block with a wide QRS complex in lead 1, AVL, and B5 and B6, preferably with maybe a notch on the top, and you have a small R wave in the RV leads in V1. Maybe a QRS complex, but it has to be a typical left bundle branch block. The patient is in sinus rhythm. QRS complex is less than 35%. And also, very important, and also been just described to you, that the patient should be on good medical therapy, good guidelines-directed medical therapy, maximum therapy, and should be at least on this therapy for 3 months before you actually subject the patient to the device, because we've seen many times, especially with all the newer drugs, that sometimes the patient will have an LV ejection fraction of 35%, but when you institute really maximum doses of treatment for heart failure, and you repeat the echo, you find the patient is actually moved out the indication for a CRT, become the ejection fraction 40 or 45%. So you have to make sure that the patient is on maximum good medical therapy before you send him for a CRT. So these are the patients who respond best. You probably ask why the guideline gives the class 1 indication to these people. Is because these are the people they do the best with the CRT. Sinus rhythm, QRS duration more than 150 milliseconds, proper or true left bundle branch block, and on good medical therapy. And if they continue to have anything between class 2 to sort of like class 4, but obviously has to be a good class 4, then you can offer the patient the device. The devices are not cheap; they are expensive. The procedures are not without their complications, but it is economically quite rewarding. There are lots of other indications for, obviously, for implanting a CRT in this patient. The class 2A, the patients who have non-left bundle branch block, sort of intraventricular conduction delay, they come into this. Patients who have atrial fibrillation, also they can be implanted with these devices. And patients who have a narrower QRS complex, they only qualify if they have a clear indication for ventricular pacing. And this is very important. Very often you have patients with complete heart loss. They come to the hospital, and without doing the echo, people go and implant a dual chamber pacemaker. Patient needing 100% ventricular pacing. After 6 months, I've seen patients going into severe heart failure because nobody checked the echo. The patient already had an ejection fraction of 35 or 40% before the pacemaker went in. So it's very important point to check the echo in patients who require ventricular pacing more than 20 or 40%. Class 3 indications, class 2B, obviously, as I said, people who have a left bundle branch block with a QRS in the range of 120 to 149. And you can still implant these people with a pacemaker if they have failed good guideline-directed medical therapy. Patients with a QRS complex less than 120 milliseconds, contraindicated. Okay. Patients with class 1 or 2 symptoms and the QRS, NYHA class 1 or 2, and the QRS is less than 150, again, CRT is not recommended. and obviously patients who are very frail and who whose life expectancy, sorry. Okay. I nearly finished. I just need to touch on to the ICD part of it, and the ICD has already been, sorry. The ICD has already been alluded to earlier on. Any patient who goes for a CRT, you have to check whether he's also a candidate for an ICD and vice versa. Patients who are candidates for ICD also, you have to check whether they require a defibrillator or not. Obviously, the choice between a CRT and a CRT P is sometimes difficult. This is just from the most recent guidelines from the European Cardiac Society. As you can see here, if the patient is really very old and frail with heart failure, it's possible that you just choose a pacemaker, because a defibrillator probably would not add much to the life expectancy of that patient. CRTP is probably better, because these people usually die of end-stage cardiac dysfunction or pump failure rather than a sudden cardiac death, as has been shown. Myocardial fibrosis is a very important entity now. Is obviously, we realize that the burden of fibrosis in the left ventricle is an indirect surrogate marker for lethal ventricular arrhythmia. So if the patient has more fibrosis on a CMR, then you have to provide it with a defibrillator, not just a pacemaker. Non-ischemic cardiomyopathy, as has been shown earlier on in the recent Danish study, shown that these patients actually don't benefit that much from the defibrillator unless they are 60 years old or less. Short life expectancy, major comorbidities, and so on. So it's a choice really that you have to make. Okay, I think I'll stop here and we'll take any questions.
Thank you very much. So